Thank you very much. Thanks for coming. It's quite an impressive program. It's my first year here, and it's amazing how many people are here and the vendors, so thank you, everybody. So I'm Ben Snyder, for those who I have not met. And I'm going to be talking about the non-operative management of hip and knee osteoarthritis. So it's osteoarthritis. Dr. Kennison talked about other types of arthritis, namely rheumatoid, psoriatic, and other types of inflammatory arthritis. Those are treated a bit differently, particularly with the disease-modifying medications that she briefly discussed. So this is osteoarthritis, otherwise known as degenerative joint disease or degenerative arthritis, kind of the wear and tear. So my background, I joined Plymouth Bay Orthopedics a month ago. I did a fellowship before that out at Stanford. My residency was up in Worcester at UMass. I did my medical degree and a public health degree at Dartmouth Medical School up in New Hampshire, and I got a bachelor's and master's in mechanical engineering at Penn State University. I'm originally from Allentown, Pennsylvania. So definition of arthritis, simply it's the loss of articular cartilage, which is a smooth lubricating surface of the joint. This is by a combination of losing the cartilage integrity over time, biochemical processes, genetics, and then the mechanical forces on the joint. So you normally have a very smooth articular surface. This becomes eroded, exposing the bone. There's bone spurs that form, and this is also can lead to cysts and hardening of the bone, tears in the meniscus, and this is really mediated by a biochemical process, certain chemicals that we'll get to at the end that are future targets of intervention. So risk factors: older age, female sex, obesity. This is the #1 modifiable risk factor. Previous injury to the hip or the knee, malalignment in knees or dysplasia in the hip, high impact activities, or muscular weakness. So the incidence for knee arthritis is about 2.5 patients, 2.5 per 1,000 patients per year. Hip incidence is about 1/3 less than that. Typical evaluation, acronym I learned in medical school was CLEAR-AST. So typically, the pain is a dull ache or a soreness. With the knee, it can be pain on the inside, the outside, and the front. The hip, it's typically the groin. It's usually made worse by walking, going up and down stairs, and with the hip, sitting and putting on their shoes and socks, usually alleviated by rest or medication or using a cane or walking stick. Usually, the pain does not radiate. That makes you think more neurologic. Associated symptoms may be swelling in the knee. You might hear some crepitus, which is some grinding or some clicking. It might have a limp. You grade it 0 to 10 out of 10. And then the timing, usually it's gradual onset. There isn't an acute injury that causes this. So the diagnosis of hip arthritis, so it's hip pain with low inflammatory markers, and then x-ray findings of arthritis, which we'll go through. The knee, it's knee pain, older age, stiffness that lasts less than 30 minutes. If it's more than 30 minutes, then you're thinking more inflammatory types of arthritis, and then the grinding and x-ray findings. So the signs on x-ray of osteoarthritis, there's 4 signs. So there's joint space narrowing, which just means wearing of that cartilage. That cartilage is radiolucent. It doesn't show up on x-rays. So as that cartilage gets worn, the ends of the bone will get closer and closer until they're actually touching. And that's where the term bone-on-bone arthritis comes in. You get bone spurs that form. You get hardening of the bone. And then you can get cysts within the bone. And it's graded by this Kellgren-Lawrence classification. So if you have some mild narrowing and some small osteophytes, it's typically classified as mild. If you have some definite narrowing, larger osteophytes, some hardening, that's moderate. And then if you have large osteophytes, bone-on-bone, deformity, that's considered severe. So the treatment is really dependent upon if it's mild or the moderate to severe. And this is a combination of how often that pain occurs, and then also if it's affecting your quality of life. Mild, it'll come and go, usually doesn't affect the quality of life, whereas the moderate severe, it seems to be persistent, particularly affects the sleep of patients, and then it does affect their quality of life in that way. So you need to really gauge the patient's understanding of arthritis. What have they tried? What have they read about? And it's really about expectation setting with the patients. This is a chronic disease that'll likely affect them, for their life. And what are their expectations? Are they willing, as Dr. Reitmeyer, I love the triad, the copers, the non-copers, and I forget the third one. But a lot of people were able to cope with this very well. And we'll go through strategies to do that. What are their expectations for the treatment? giving them good educational and written materials, and referrals to the appropriate complementary providers. So what I'm going to do is talk about the evidence-based treatment that our National Academy, the American Academy of Orthopedic Surgeons has put out. This is based on evidence for the knee. It is evidence, this was approved in 2013, so there has been 5 years since this has come out. This is the most recent guidelines, but 5 years in this day and age is an eternity. So there is new evidence that has come out, but this is, the guidelines that, have been approved by our academy. The hip is newer. That came out last year in 2017. So for the knee, there's over 10,000 studies reviewed. Treatment options for mild knee arthritis is really non-pharmacologic treatment that should be recommended for the patient's lifetime. So exercise is the #1 recommendation to keep these patients moving, to keep their joints limber, keep their muscles strong. What I tell patients is osteoarthritis, while it may cause pain and be hurtful, you're not usually doing harm to the joint by the light activities that you're going to participate in. So nothing that they will do will cause further damage. I'm not expecting them to get out, what they should avoid is, running long distances, high impact activities, and a lot of them laugh at me when I say those things. So oftentimes this is best treated with just a referral to physical therapy, where they're going to work on low impact aerobic fitness, strengthening, stretching, and then education on what they should and should not do, and how to cope with this in their daily routines. So there's very strong evidence behind this. And again, the easiest thing is a referral to the physical therapist. There are some self-management programs. One that our academy has recommended is this arthritis self-management program, which is actually out of Stanford. So the arthritis self-management program, it's really about getting people together in groups, doing light exercises, stretching, balance, and kind of going over those coping skills that they can kind of help each other, kind of the group therapy. One that I dealt with up in New Hampshire was this Bone Builders, and this was led by local community representatives. They would meet twice a week, and then they're doing strengthening, balance, stretching exercises, and then coming up with coping strategies on how to deal with this. The next recommendation is weight loss. So chemicals produced by the fat cells actually cause inflammation. You should recommend these patients to lose 5 to 10% of their body weight in the first 6 months. If they can reduce their BMI by 2, then it's been shown to have 50% less symptoms. What I talk to patients about, I don't expect them to get out and lose that weight by exercise. It's really about calorie restriction. So a pound of fat is 3,500 calories. If they can cut out 500 calories a day, that's a pound of fat a week. And usually you can find that in sugary beverages or a snack, and it has a big effect. Mainly because in the knee, 5 to 7 times your body weight goes through the knee with every step, and so every pound you lose, is 5 to 7 pounds less on the knee. So combining this with exercise, very effective, moderate evidence behind this. So the topical anti-inflammatories is the only pharmacologic recommendation you should give for patients with mild arthritis. This is really helpful in superficial joints, namely the hands and the knees. The most commonly prescribed is diclofenac gel, and it's something that should be used a few times a day for several weeks on end. The only downside, it can cause a small rash. The other thing I recommend is topical capsaicin. This is a hot pepper derivative. Works by downregulating the pain nerve activity and also depleting some pain chemicals. It creates a little local burning sensation, which if patients are very sensitive, might be intolerant of. So typical, these are typical dosages, which you probably cannot read. Sorry. So the overall management of mild arthritis is educating the patients, recommending exercise, again, referring to physical therapy, weight management. If this does not help them, then considering a topical anti-inflammatory or cream. And really recommending this for the rest of their life. If they continue to progress or have persistent symptoms, then you're thinking this is more moderate to severe. So the treatment options for moderate to severe, still exercise is #1. Even patients that are awaiting total knee replacement for end-stage arthritis have found benefit in exercise. For these patients, I emphasize aquatic exercise. What I talk to them about is they get the benefit of the buoyancy of the water, so they're getting less forces through the knee. They get resistance from the water for strengthening, and usually the water is warm, so they get a soothing effect. So again, this has strong evidence. Knee braces, if somebody is younger, more active, but they have more advanced arthritis, this is something that they can use for more vigorous activities. And what it does is it actually realigns the knee to take weight off of the affected side of the knee and place more weight on the unaffected side. The trouble with this is that they can slip, and because of that, or not fit well, and so they have lower compliance rates. So there is actually been found to be inconclusive evidence where there has been improvements in their pain and function, but those benefits, how meaningful they are unclear. The next recommendation would be a cane or a walking stick. This is used in the opposite hand on the side where they're having pain, and it just works by offloading that joint. So you're shifting the center of gravity, from the middle of your body to that side, and therefore offloading that joint. Other option is more of a psychological intervention. It's something for somebody that has pain throughout their whole body and multiple joints, and it's really developing coping skills around this painful stimuli which the arthritis causes. There has been some new research into this, but that is still limited. So the next step would be considering oral analgesics. Acetaminophen, which is Tylenol, is kind of the first step. While it's been found to be more effective than placebo, it's actually been found to be less effective than non-steroidal anti-inflammatories. You have to watch out with patients with liver disease. So the non-selective anti-inflammatories are kind of the mainstay. Ibuprofen, which is Advil and Motrin, or Aleve, which is naproxen. This is something that should be taken on a regular basis, 2 to 3 times a day. It does have a 2 to 4% chance of having abdominal discomfort or fluid retention, so you want to avoid this in patients that have a sensitive stomach, have had prior GR bleed, or on other anticoagulants, or have severe cardiovascular disease. In that case, you may consider more of a selective anti-inflammatory, which is a COX-2 inhibitor. Inflammatory cascade has 2 arms. One's called the COX-1, the other one's called the COX-2. The COX-2 is really the painful arm. There were certain medications, you might have heard of Vioxx, 10 or 15 years ago, that found to have higher rates of cardiovascular disease associated with them. Well, there's newer studies, particularly around celecoxib, which is Celebrex, which has been found to be safe. It has fewer GI side effects, and a recent randomized controlled trial has shown that it's been non-inferior or equivalent to using ibuprofen or naproxen in regard to cardiovascular issues. So Tramadol would be the next step. This is an opioid analgesic that works both on binding that opioid pain receptor in the spinal cord, but then also acting as a serotonin norepinephrine reuptake inhibitor. And there has been some good evidence behind this in reducing pain and improving function. This can come with some side effects such as nausea and vomiting. A medication that the rheumatologist prescribe a lot is Duloxetine, otherwise known as Cymbalta. This is just a serotonin norepinephrine reuptake inhibitor. There have been randomized trials done on this showing good improvements in pain, but this does also have similar side effects: nausea, vomiting, some dizziness, dry mouth. So our Academy's recommendation, there is strong evidence behind anti-inflammatories, whether they are the oral pills or the creams, and Tramadol. We had inconclusive evidence on whether to recommend Tylenol or pain patches, and I'll just also say that opioids should never be prescribed for arthritis, and we'll get back to that a bit later. So the next more interventional step would be an intraarticular corticosteroid injection. Dr. Tran talked about this with the spine. This is very commonly given with hip and knee arthritis. What I tell patients is that this is a short-term solution for a chronic problem. Dr. Oliver will tell his patients it's like dumping a bottle of Advil right into the knee, right where you're having the issue. Well, what it does is it helps with the pain, but what I believe provides long-lasting treatment is rehab, so stretching, strengthening, and then also the weight loss. And so if you get the pain under control, those patients can more effectively do their therapy, which provides more of the long-lasting benefit. So it works on, blocking some of these inflammatory cell lines, reducing inflammatory biochemicals. The trouble is you cannot give it too often, as it has been found to be toxic to some of these cartilage cells. Therefore, I tend to try to avoid this in young patients that still have a lot of healthy cartilage in their joint. So you should limit this only to 3 to 4 times a year, and you have to watch for this post-injection flare. When looking at all the trials, these were randomized compared to placebo. It is inconclusive whether these actually provide a benefit. They have been found to decrease pain by 1 point out of 10, increase function by 1 point out of 10, with similar side effects to placebo. So whether that's kind of clinically meaningful is kind of yet to be determined. So in regard to this, there was something that we used to do called a needle lavage, where you stick a needle in the knee or the hip and just flush it out with sterile saline. That's been found to be non-effective, and there's good evidence that it is non-effective. So again, the treatment for moderate to severe, again, exercise, weight loss, considering a brace for more active patients, cane or walking stick for older patients, cognitive behavioral therapy for coping skills. If that isn't working, then anti-inflammatories, either topical or by pill. If that isn't working, then considering Tramadol or Duloxetine. And if that's not working, then an intraarticular steroid injection. And at that point, you're probably considering a referral to orthopedic surgery, for further surgical intervention. So treatment of hip arthritis, again, these were 7 recommendations that just came out last year. Strong, moderate, low evidence, or no evidence, and then consensus. We'll quickly go through these. So similar to knee, the anti-inflammatories had very strong evidence that they provide very good pain relief and improve the patient's function. Physical therapy, also strong evidence to improve the function, kind of reduce pain. Intraarticular steroids actually in the hip have found to be incredibly effective. So there's actually good, strong evidence behind that. So these are the different recommendations. You're not going to be able to read it, but based upon our academy, the rheumatologist, and then the arthritis research academy. And essentially, the only differences are that Tylenol is used a lot with the rheumatologist and the researchers, where it had kind of inconclusive evidence in our academy. The steroids recommended was inconclusive by us, but actually recommended by the rheumatologists and researchers. Those are kind of the big differences. So non-evidence-based treatments, so these are treatments that just have evidence that do not have good evidence behind them. One are shoe insoles, which would help theoretically deviate your leg from side to side to try to offload the joint. These have not been found to be effective and have moderate evidence that they do not work. Glucosamine and chondroitin, these compose the building blocks of your synovial fluid. There's good evidence, randomized trials that show that they are no better than placebo. This is both in hip and knee arthritis. Other nutritional supplements you might have heard of: fish oil, turmeric, vitamin D, omega-3 fatty acids. Again, there's kind of low evidence that these work. What I tell patients, if they're asking about them or have tried them, is that the evidence is not great, but there's actually a few downsides to trying them other than the cost. So the only thing that they would be out is the cost. TENS units, which work on this gate control theory of pain, have not been found to be effective. They think there's a strong placebo effect with this. So with other alternative therapy modalities, acupuncture, there's actually strong recommendations against this. Using these 10 units or modalities, are inconclusive evidence behind this. And then massage, also inconclusive evidence. So the intraarticular viscosupplementation, so this is the rooster comb injections, the synthetic joint fluid. These are hyaluronic acid, which is the building bone of your synovial joint fluid. It's thought to provide more lubrication in the joint, provide anti-inflammatory effects, possibly protect the cartilage cells. This has not been borne out to provide a good relief in these randomized trials, and insurances have caught on to this, and some are not paying for it. So the viscosupplementation in the knee, there's actually strong evidence that they cannot recommend it. Again, that's based upon 2013 data. There have been more studies since then on newer types of viscosupplementation. And then in the hip, again, strong evidence that it did not provide any benefit. Weight loss, although not studied in the hips, there's consensus that it will improve patients' function and pain, mainly by reducing those joint forces. And in opioids, again, should never be prescribed for arthritis. Been found to be very poor in controlling long-term chronic pain, and we all know about the addiction potential now. So newer emerging therapies, very quickly, platelet-rich plasma injections. Again, this is an area that there's probably been a lot of evidence in the past 5 years. Evidence that was looked at had a high risk of bias and variability in their effect. They are prepared in different ways. A systematic review showed that there's limited number of good trials. They tend to be of low quality, so they say that more trials are needed. There have been found some benefits, but again, it's low quality evidence. So because of that, it's inconclusive, whether it's effective in knee arthritis, and also lack of trials in hip to determine if it's effective there. So medical cannabis, there is a desire among patients to try to implement this into their pain management strategies. There are endocannabinoid receptors in these arthritic joints, and they have been found to have some benefit to more neuropathic pain, but again, that evidence is pretty low quality. Regenerative therapy, which is stem cells, that's still being developed in the laboratories. Good human trials have not been accomplished yet, but that's something to kind of keep an eye and ear out for. And then actually targeting these chemicals that break down the cartilage using antibody medications, the MABs, the molecular antibody medications, to actually block the upstream cause of that cartilage degeneration. That's something that we will see in our lifetime. So the take-home message is that there is strong evidence for weight loss, physical therapy, and anti-inflammatories in the initial treatment of hip and knee arthritis. Moderate evidence supports corticosteroid injections, and currently there's limited evidence for the viscosupplementation and biologics. But again, that's stuff to watch out for because there are new and novel therapies that are coming out and are going through very good, high-quality studies. So thank you very much.